to get to acid base, which is fun. But anyways, so now we already saw the causes and the pathogenesis of hyperkalemia. So now we're just going to look at the clinical manifestations. So do you notice some commonalities, nausea, vomiting, with some of these? So I have a little worksheet in Kruger-View that says signs and symptoms similarities. So you can fill that out, and when you do that, you'll see the answer key. Well, answer key will pop up underneath it. It's like a condition. If you open up that file, the answer key will open. So it's called signs and symptoms similarities, because you're going to get so bogged down with all these signs and symptoms, you have to create like an acronym or create some kind of relationship with them. So sometimes just looking at what signs and symptoms are similar will help. So the GI, and I separated them into systems. So cardiovascular, so when you think potassium, think the heart. So changes in the electrocardiogram, risk of cardiac arrest. Now, one of the things in hyperkalemia, when it gets very high, the heart will stop. And this is what they use when they, when people are on death row. What is the word? I don't forget when they die,
Execute them.
They execute them, yes, I guess. It's awful to think about, but that's what they give them. They give them IV push potassium. They also give them morphine and Versed too, which is a sedative. But they give them high doses of potassium because it instantly stops the heart. It's more humane. So you never, ever, ever, ever IV push potassium. You never, ever, ever IV push potassium because you can kill your patient. All right? So, the big thing, now you haven't learned about EKGs yet, but when the potassium goes up, we're going to see something called tall peak T waves. So, this is a normal EKG. You've got a little bump here, a big bump here, and a medium-sized bump there. You're going to learn about what all these bumps are later. But in hyperkalemia, see this is the T wave after the pointy thing. This T wave gets really tall. It's taller than what this is called the QRS. It's basically PQRS-T. So this, the T wave gets taller than the QRS. So if you put somebody on a cardiac monitor and you see those tall peak T waves, you're like, hey doc, can we get the chemistry level? I think his potassium's elevated. That's going to be a sign of high potassium. Okay. So tall peak T waves. All right, muscle cramps, paresthesia, weakness, and dizziness. Because at the end of the day, both hyper and hypo will cause muscle weakness. So now here's your cartoon thing. So you've got muscle twitches, irritability and anxiety, decreased blood pressure, EKG, dysrhythmias, abdominal cramping, and diarrhea. Now, severe diarrhea. When I say severe, like diarrhea for 3 days. Diarrhea for 2 days, like really bad diarrhea is going to cause hyperkalemia. Okay. All right. And then another question. So give me your 1, 2, 3, 4 fingers. Disorders of which ion will have the greatest effect on the membrane potential? Yeah, so it's that resting membrane potential, so it's potassium. So potassium, this thing, pathogenesis, it changes the resting membrane potential and changes the excitability of those cells that they can contract. That's why, at the end of the day, it does cause weakness in our skeletal and muscle, our heart muscle, smooth muscle and skeletal muscle.
If they had put sodium as an answered question, would it be sodium over potassium then?
Potassium has the greatest effect on our membrane potential, like this resting membrane potential. Sodium has the effect on osmosis. When you think sodium, think osmosis. Because that's how the water getting in and out of the cell is controlled by that sodium. All right. All right. So vitamin D, calcitonin, and parathyroid hormone. So this is going to talk about our calcium levels, our phosphate, and our magnesium. So vitamin D. So if we have vitamin D in our gut, what are we going to absorb? Calcium. So you actually need vitamin D to absorb calcium. We get vitamin D from what?
The sun.
The sun, fortified milk, oily fish, Back in the day, I think we ate a lot more fish than we do now. Fish used to be cheap, now it's expensive unless you fish it yourself. But, so there's that part, and also it helps us absorb phosphate. Now, calcium and phosphate are big in building what? Remember osteoblast? Your bones. So you need calcium and phosphate to build your bones. Now calcitonin, so look at it, calcitonin, it's a hormone that's secreted by your thyroid gland when your calcium gets too high. When your calcium gets too high, your thyroid gland will secrete this calcitonin. Calcitonin tones down the calcium. Calcitonin brings down the calcium. And also people say calcitonin puts the bone in. Calcitonin puts the bone in because it puts the calcium back into our bone. It tells the calcium, get out of the bloodstream and get into the bone. Okay? Now the parathyroid are 4 little glands that sit behind our thyroid in our neck. And the parathyroid secretes parathyroid hormone. When our calcium gets too low, our kidneys will say, hey, don't pee out the calcium, hold on to the calcium. And in our bones, if our calcium gets too low, the parathyroid hormone says, hey bones, you gotta pull out some of that calcium, put it in the bloodstream. We've got low calcium in our bloodstream. And it also tells our gut to absorb more calcium. So our gut, our bones, and our kidneys are part of the system that control our calcium, especially when it gets low. Okay? And calcitonin tones down the calcium when it gets too high. So there's that homeostasis, constantly in balance, right? Your body's constantly keeping the calcium in balance. All right. So, so we get it through eating food, absorbed by the intestine, filtered through the kidney, reabsorbed in the kidney if we need to keep it, and eliminated in the urine if we have too much of it. The calcium, phosphate, and magnesium. Now, calcium. Calcium is bound to the albumin. You don't really have to memorize that too much, but calcium can bind to citrate. And something in when we donate blood or we receive blood, blood that's donated or patients who receive it, it has citrate in it. And it can bind to the calcium and make people have low calcium levels. I had a friend of mine who was donating platelets, and that takes a while. You sit there for a while to donate platelets. And it was a friend of mine, she's a nurse educator, and she told the nurse, she goes, my lips are going numb. And that is a sign of what we call circummoral numbness of low calcium. And she knew this, donating blood, have citrate in it, and the nurse gave her 2 Tums. What's in Tums? Calcium. And the numbness went away. So, but my friend knew that numbness around the lips is a really telltale sign of low calcium. It's another clinical manifestation. So how do we gain it? So what foods have calcium in them?
Milk. Dairy.
Yeah, milk, yeah. Well, the alternative milks are fortified with calcium, but soy is high in calcium. Just tempura, soy, tofu is high in calcium. Dairy products are high in calcium. They're also high in phosphate as well, your dairy products, like cow's milk. Almonds, so almond milk is high in calcium. Chia seeds, chia. You can also put chia seeds in your milk or whatever, and it makes that pudding, you know. They look like tadpoles to me when you see that. It's still good. Of course, we need our vitamin D to absorb our calcium. And losses, of course, you know, from urination, you know, and we don't eat, we have low calcium if we don't eat enough of it. Yeah, so. All right, causes of low calcium. So the calcium must be less than 8.5. So there might be some diseases where the calcium cannot be pulled from the bone. Kidney failure causes low calcium. And the reason for this is because your kidney converts the vitamin D that is used to help you absorb the calcium. And so if the kidneys are broken, they don't convert that vitamin D to help you absorb the calcium. That's why it's also because you're peeing out phosphorus. And protein binding and chelation such from blood transfusions and donations. Hypoparathyroidism, so someone who has a disease where their parathyroid is not functioning very well. Low vitamin D, chronic diarrhea, malabsorption syndromes like, what's the gluten? What am I goodness?
Celiac.
Celiac disease, thank you. My brain, celiac disease, where they cannot process gluten. Hypomagnesemia, now magnesium and calcium are like best friends. They kind of go together, but they have different pathophysiology. In alkalosis, our calcium is also low, and people who have an inflamed pancreas, their calcium is low. Now, pathogenesis, so the big thing, so calcium has a lot to do with our neuromuscular excitability. It has a lot to do with our action potential in our neurons to our cells, neurons to cells, so the action potential. So if the calcium is low, it makes our action potential very excitable. Makes our cells are very excitable when the calcium is low. And so we're going to have twitchiness. The patient's going to be twitchy. If we tap on their cheek here on their 7th cranial nerve, they're going to have a twitch on their face because everything's excitable. The neuromuscular system's excitable, and that's called chopsticks. When you tap on the cheek and it twitches, chopsticks. And so just say chopsticks really fast a whole bunch of times and you'll get the chopsticks. Chopsticks, 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 chopsticks. That's how I pronounce it. Another thing is, I'm getting from pathogenesis to clinical manifestations, which is a big goal here. You put a blood pressure cuff on really tight for 3 minutes, they'll have something called trizo, where they have a carpal pedal spasm, where their wrist and arm will flex if you put the blood pressure cuff on too tight. So convulsions and seizures, tetany means tight. Their muscles get tight and then they can start having seizures. So spasm, stridor, laryngospasm, the larynx spasms, and what do you think that is going to cause? Airway, they're not going to be able to breathe, right? So laryngospasm, muscle spasms, muscle tightness, tetany, seizures, chopsticks, trizos, everything because the action potential is excitable when the calcium is low. So normal neuromuscular excitability is imbalanced and we have increased neuromuscular activity. So the action potential, so highlight that. When you think calcium, action potential. Potassium, resting membrane, that's your pathogenesis. And your clinical manifestations there. So you've got your cats, your 4 cats. Convulsions, arrhythmia. So we can have heart, because if the heart's excitable, we're going to have these irregular beats. Okay? So there's your trizos, that's how you spell it, the carpal pedal spasm when you leave a blood pressure cuff on tightly, when you pump it up for 3 minutes, and then positive chopsticks when you tap on the cheek and it twitches. Yeah, everyone's like, I have no calcium. Fine. And that circummoral numbness around the mouth, right? So here's, so that's hypocalcemia. Now remember, low calcium in the bloodstream, right? Low calcium in the bloodstream. Now, hypercalcemia, greater than 10.5. So etiology, the causes, too much vitamin D and too much calcium. Years ago in the 90s, everyone was into this shark cartilage. And the shark cartilage had a lot of vitamin D and people were overdosing on that and getting high calcium. The parathyroid, they have high parathyroid, maybe hyperparathyroidism. Now, some tumors can secrete parathyroid hormone and cause high calcium. When patients are bedridden or they're immobile, they're bedridden, their calcium goes up. So you're going to learn about getting your patient up and walking them so that weight-bearing exercise, like lifting weights and jogging and putting weight on your bones, helps the calcium go back into the bone. Because remember, we have too much calcium in the bloodstream. So if we do weight-bearing exercises like lifting weights and jogging, jumping jacks and stuff, it puts pressure on the bone, so therefore the calcium leaves the bloodstream and goes into the bone. So that relieves the hypercalcemia. The patient's not peeing it out. There's drugs called thiazide and lithium. Now the pathogenesis is that that decreased neural excitability. So the action potential's not very excitable. So it's going to be the opposite. We're going to have weakness. Where we had twitching, now we're going to have weakness and hyperkalemia. So smooth mush, the cardiac muscle will be relaxed. So what do you think our heart rate's going to be? Slow, like bradycardia, slow heart rate. Exposure of the kidneys to high concentrations of calcium, and that can cause the kidneys can get damaged. What do you think? Well, let's just go to clinical manifestations. You see some commonalities: anorexia, nausea, emesis is vomiting, constipation, fatigue, polyuria, peeing out. Now we've got too much calcium, so the body's trying to get rid of it. So peeing a lot, muscle weakness, decreased reflexes, headache, lethargy, confusion, coma, because everything slows down. So we talked about the heart rate would be slow, and also kidney stones or renal calculi. Renal calculi means stone in the kidney, because majority of kidney stones are made out of calcium. So people who have kidney stones, they get worked up to see if they have hyperparathyroidism. So kidney stones. So now here's your acronym for signs and symptoms: bone pain, because the calcium's in the wrong place. The calcium's in the bloodstream. Arrhythmias, cardiac arrest, kidney stones, muscle weakness, and excessive urination. So back me. So, all right, alterations in blank may result in hypercalcemia. Give me your 1, 2, 3, 4. It's going to be vitamin D. Vitamin D. We need it to absorb our calcium. All right. So women who have osteoporosis, or men that have osteoporosis, are going to take vitamin D and calcium supplements. Osteoporosis is the brittle bone. The bones get soft. Okay, so that's calcium. So we might make it to ABGs. Good. Okay. So phosphate is another one. Now phosphate helps us build our bone. It's part of our ATP. The ATP, P, and phosphate. So if we don't have enough, we're not going to have that ATP pump, that sodium potassium pump. So it's part of our cell, is right. Remember our lipid phosphate layer? It's part of our cell. And it's part of our DNA, RNA. So we need phospholipids and phosphorus in our body. It does serve as an acid-base buffer. It helps us deliver our oxygen, and it helps us with our normal white blood cells and platelets. So we need phosphorus. If our phosphorus is low, we're going to have low white blood cells. So causes of hyper and hypophosphatemia, so page 166, 67. Hypophosphatemia, so less than 2.5. Depletion of phosphate because of insufficient absorption. I mean, the hypos are going to be because we're not eating it, right? That's easy. Bless you. So we've got shifting of phosphorus going from the cell to other parts of the body, and the kidneys are getting rid of it. The kidneys are abnormally getting rid of too much. So hyperphos, it's greater than 4.5. Now the kidneys are not excreting it. And also rapid redistribution from intracellular to extracellular, so it's coming out of the cells and going into that vascular space. And too much intake of phosphate. Phosphate's like whole grains and seeds and stuff like that. All right, so phosphate, here's a little thing, vitamin D. Come and get your intracellular phosphate. We have a high energy structures, creatinine phosphate, ATP. ATP provides that energy to your cell, and so it helps regulate It's regulated by the parathyroid hormone and vitamin D and calcitonin. So let me tell you, at the very bottom it says if the phosphate is up, calcium is down. Calcium and phosphate are enemies. They're enemies. So if the phosphate is up, calcium is down, they avoid each other. They do not like each other. If the calcium is up, phosphate is down. They have the reciprocal relationship in the bloodstream. They're opposites. It's just organic chemistry. So calcium up, phosphate down. Phosphate up, calcium down. They're just opposites in the bloodstream. Okay, so clinical manifestations of hypophosphatemia. So your neuro manifestations, they can have a tremor. Ataxia is when you can't do this, the finger to nose thing. You're like, you know, like if you ever get pulled over, I don't know if they do this anymore, and you make you do those drunk tests, you can't walk, that kind of unsteady gait, you can't move very smoothly, like jerky movements, that's ataxia. Paresthesias, so that numbness, confusion, stupor, which is like falling asleep, going into a coma, seizures, neuromuscular, muscle weakness. Gosh, doesn't that sound like hyperkalemia? Remember they're opposites, right? Bone pain, osteomalacia, which is that low vitamin D. They can have hemolytic anemias, platelet and impaired white blood cells, because we need phosphorus to make our cells. That's why if we don't have it, we're not going to have enough cells. Now, hyperphos, I want you to think that reciprocal relationship, think hypocalcemia. So you're going to see the paresthesias and the tetany and the seizures. And then you're going to see the hypotension and the cardiac dysrhythmias. So just think opposite. So hyperphosphatemia, think of symptoms of hypocalcemia, because they're opposite. Right. Any questions on phosphorus, calcium? Okay, magnesium. Again, it is essential, of course, for ATP, the kidneys. We get it from our diet. A lot of nuts and seeds and chocolate, dark chocolate, has a lot of magnesium in it. And excreted by the kidneys. Now, the pathogenesis. Magnesium competes with acetylcholine in our neuromuscular junction. So this is the neuron and this is the muscle. So if we've got low magnesium, we've got hypomagnesemia, we have too much acetylcholine. So low magnesium is going to cause, acetylcholine is a neuromuscular hormone or neurotransmitter that causes us to move. So if we have too much acetylcholine, we're going to be twitchy. So hypomagnesemia, the signs and symptoms look a lot like hypocalcemia, because they're best friends. Calcium and magnesium are best friends, where calcium and phosphorus are enemies, they're opposites. So we have a lot of the same symptoms, but the pathogenesis is different. So magnesium competes for acetylcholine. Now if we have too much magnesium, and we don't have enough acetylcholine, we're going to have relaxation. Does anybody take like magnesium to sleep or relax? Yeah. Did you have a question or just? Yeah, no. Yeah, we could take calcium and magnesium at night. They have this powder called Calm. You can drink. Tastes like raspberries or lemons or whatever, and it helps you relax your muscles and helps you sleep. Makes you sleepy. So magnesium is a muscle relaxant. Magnesium is also in Epsom salts. Have you ever taken an Epsom salt bath when you had muscle cramps after a workout? That's why it helps relieve those muscle cramps. So too much magnesium, relaxation. Not enough magnesium or hypomagnesemia, excitability, cramping, muscle cramps, stuff like that. Because it's all about competing for acetylcholine. So don't you see how knowing the pathogenesis links to the clinical manifestations? So the big thing on your test questions, I might say your patient has muscle twitching. So what's the cause? And you might have to say too much acetylcholine, action potentials, resting membrane potential, osmosis gradient from sodium or whatever. So you have to know your pathogenesis to link to your clinical manifestation. So let's look at the etiology, the cause. So alcoholics have low magnesium because they're just malnourished. They drink all day and they don't eat. They're malnourished. So then the malnourished, starved patient. People who have malabsorption issues like celiac disease, small bowel surgery, where you absorb your nutrients in your small intestine. Parenteral hyper, like just getting a lot of magnesium in your IV, and just so you're eating a lot of calcium without magnesium. So that's impaired intake, or you could lose it. So you could not take it in or lose it. So diuretics certain medications can make the patient pee it out. To hyperparathyroidism and hyperaldosteronism and diabetic ketoacidosis and magnesium wasting kidney disease. So those are just some diseases that go with it. So when you think of hypomagnesemia, when I think of magnesium, think about the sheriff. And I got this from Simple Nursing. The sheriff's in town or not in town. Bless you. Hypomagnesemia, the sheriff's not in town. So we've got this excitability from too much acetylcholine. And so everyone's going crazy shooting everybody. Woo, 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 woo. Everything's excitable because the sheriff is not in town. Everybody's shooting everybody. So the magnesium can be less than 1.8. The patient can have those personality changes. The cryophorum, just twitchy movements, basically just means twitches. Nystagmus is when the eyeballs wiggle back and forth involuntarily. Tetany is that tightness. Babinski is when you tickle the foot and the toes fan out. Anybody tickle your foot, what happens? You curl up your toes, right? That's normal. But the toes fan out. Chopsticks and trizoes, we saw that in what? Low calcium, right? Tachycardia, hypertension, and cardiac dysrhythmias. The big cardiac with dysrhythmia with low magnesium is torsades de pointes, which is this form of ventricular tachycardia. So if you see that, I guarantee you the doctor is going to say, is this patient an alcoholic? I bet you $5. So this patient, an alcoholic, or malnourished. So that torsades de pointes, it's French, but it's just a form of ventricular tachycardia, low magnesium. So, now here's the sheriff thing. The sheriff's not in town, so we have all these twitchy people, basically. We have the person drinking a lot of beer, and diuretics, stuff like that. And causes of hypermag, excessive intake or decreased excretion, so they're eating too much of it. Also, people, there's a certain hypertension disorder in women who are pregnant called preeclampsia, and we give them magnesium to bring and calm everything down, right? And the preeclampsia can also cause seizures, and then their kidneys are not excreting it, so kidney disease and acute renal failure. So the kidneys aren't working. So hypermag, think the sheriff's in town, everything's calmed down, nobody's shooting anybody up, everything's calmed down. So the lab is going to be greater than 3, so everything's calmed down. Lethargy, hyporeflexes, confusion, coma, everything slows down. Cardiovascular, hypotension, cardiac dysrhythmias, cardiac arrest. So those are some of your clinical manifestations. So that's magnesium. And a lot of elderly people who take a lot of antacids can have magnesium in them, and they can overdose. You can take a spoonful of Epsom salts in some water and drink it, and it makes you poop, right? Because it'll soften the stool, and a lot of elderly are addicted to it because they get constipation. So hypotension and respiratory depression and bradycardia, aren't that airway, breathing, circulation issues? Airway, breathing, circulation issues. Okay. Woohoo, that was electrolytes. Wow. We might get through this. It's a lot though. I know. It's a lot. Questions so far? Y'all need to get up and stretch. Shake it off. You're good. Okay. Acid base. So we're going to talk about acid and then base. We call that alkalosis. So this is drawn by arterial blood gases in the state of Georgia. Respiratory therapy does this. Now in California, I was able to draw the ABGs. Different states have different scope of practice for nurses, usually in the radial artery. Now the pH is the percent of hydrogen or the acid. So when you think hydrogen, think acid. So hydrogen is an acid. And PCO2 means, you might see P lowercase a CO2, and that's just the pressure of CO2 in the artery. And that's an acid. So when you think CO2, think acid. When you think bicarb, that's a base. So if you understand which one's an acid, which one a base, you're going to be able to figure out your ABGs. Now, the three things that we really need to figure out our ABGs are the pH, the CO2, and the bicarb, the carbon dioxide. We really don't use the oxygen, the partial pressure of arterial oxygen, to figure out what acid-base imbalance they're in, but we need to know what the oxygen level is, because 80 to 100 is the normal oxygen in the arteries. And let me just tell you a little side note to put in your back pocket for med-surg. If the PaO2 is less than 60, we have respiratory failure. We saw that a lot in COVID patients. Their PaO2 would go less than 60 and they were put on a ventilator, right? So here's your normal ABGs. Now 7.35 to 7.45. So 7.4 is basically normal. Less than 7.35 is acidic. So you see that D there? Acidosis down, D with the pH, down with the pH. So the pH goes down with acidosis. And in alkalosis, greater than 7.45, there's a K in alkalosis or alkaline, and you kick it up. You kick up that pH. So that, if that helps you remember it, trying to give you ways to remember this stuff. CO2 or carbon dioxide, 35 to 45. You have to memorize these. Now our lungs get rid of our CO2, right? We blow out our CO2. So when you think CO2, think acid, think respiratory. So I want you to associate with that. Now the bicarb, HCO3 negative, is the metabolic component. It's 22 to 26 and it's a base. So when you think bicarb, think base, think metabolic, 22 to 26. Right? Just those are the normal levels you must memorize. So there's just your cartoon. Alkalosis, kick up the pH, greater than 7.4 or 7.45. Acidosis, sliding down the pH, less than 7.4 or 7.35. Okay. So we have to talk about the pathogenesis here. So how does the body regulate the pH? So we have these chemical buffer systems. If you remember the buffers, they accelerate the chemical reaction. So our lungs, we have a chemical process in our lungs, and our lungs can either eliminate CO2 by breathing fast, right? Or hold on the CO2 by slowing down the breathing, right? And CO2 is a acid or a base? Acid, okay? So if someone is breathing fast, they're losing their acid. So what imbalance are they going to be in, acid or base? Base, because they're losing the acid, so they're going to be more basic. Alkalosis, does that make sense? Okay. If someone maybe got a narcotic and they're not breathing acidosis, they're holding on to the CO2. So if they hold on to the CO2, which is an acid, they're going to have acidosis. Does that make sense? So just knowing, are they gaining an acid or losing an acid? Are they gaining a base or losing a base? So the kidneys, they can eliminate a hydrogen ion or reabsorb the hydrogen ion, or they can eliminate the bicarb or reabsorb the bicarb. So the kidneys control our acid base by, let's say they're acidotic. What are they going to pee out? The hydrogen ion, right? Because hydrogen is an acid. What are they going to retain if they're acidotic? Bicarb, because bicarb's the base. Okay, because they're gonna need more base to kind of mix in that acid, right? But they need to pee out the acid. So they're gonna pee out the hydrogen ions or eliminate. Now reabsorb means holding on to. So if they're alkalotic, they're going to pee out the bicarb and reabsorb or hold on to the hydrogen, the acid. So that's how the body balances. Now only the lungs can get rid of CO2 and only the kidneys can get rid of or retain the hydrogen or bicarb. That's just what they can do. Okay? Questions so far? So more pathogenesis, handling your body's pH, how your body regulates it. So I got this from interactivebiology.com. So your body either is going to remove or add an acid. That would be for what disorder? Well, if they remove an acid, they have acidosis, right? If they add an acid, they have alkalosis. Okay. Or they're going to remove or add a base, right? So the organs that do that are our lungs and our kidneys. Which one do you think is going to react first? The lungs, because we can change our breathing, right? We can either breathe fast or breathe slower, right? So we can change our breathing. So the lungs kick in like within minutes. The kidneys take 3 days to weeks to kick in. So the kidneys take a while to kick in to put us back into homeostasis. Okay, but the lungs can kick in right away. All right. So let's look at acidosis. The body experiences a low pH because the D, you slide down the pH. So the body is going to be acidotic. How do your kidneys and lungs regulate this? So the respiratory compensation, you're going to hyperventilate because you're going to get rid of an acid, right? CO2. We call that Kussmaul's respirations. They're something very fast and very deep. So they're deep breaths, but fast and deep breaths. So they're blowing off their CO2. I got a video coming up next or soon of a little boy who is having diabetic ketoacidosis, and he's breathing deep and fast. His body's compensating. Now, also acidosis, what do the kidneys do? The kidneys are going to excrete the hydrogen and retain the bicarb because they got to mix that little bit of base in there to balance that acid. So that's how, this is the pathogenesis of how the body balances back. Now in alkalosis, the body experiences a high pH, so they're alkalotic, they're more basic. So what do you think is going to happen with the respiratory? They're going to slow down. Now, is that dangerous? That's an airway issue, right? That's a breathing issue. So that's very dangerous for a patient to be in an alkalotic state and they slow down their breathing because they could get what's called hypoxia, which is low oxygen, so lack of oxygen. Now, the kidney compensation, they're too alkalotic, so they're going to excrete the bicarb and retain the hydrogen ion, just to mix that acid, a little hydrogen acid in that base to balance it out. Questions on how the body compensates? Make sense? Okay, all right. Now let's get into each derangement. So metabolic acidosis. Now acidosis, the pH is down, the bicarb is also down. Now metabolic means the body, something in the body, the gut, the kidneys. Okay, so look on page 180, there's a table there, 817. So they've either gained an acid somehow or lost a base. So how can a client gain an acid? What would be a way to gain an acid? That might be a little bit harder. What electrolyte changes with acidosis, I said? Hyperkalemia. So hyperkalemia and acidosis go together. So what causes hyperkalemia? Increased potassium, yep, but what causes the increased potassium? The cells lysis. So like burns, crushing injuries, anything where cells are dying, cardiac arrest, our patients are gonna be in acidosis because the potassium is now shifted from inside the cell to the blood vessel, because the cells are dying. And they can lose a base by, kidney issues, stuff like that. So let's just look at this. So our metabolic acidosis, so some of the causes here are diabetic ketoacidosis. The diabetic patient has their blood sugar's gotten very, very high, like 600. The normal is supposed to be like 120. Severe diarrhea. Now this is like very bad diarrhea because cells are starting to die. Renal failure and shock. So they don't have blood circulation. If you don't have blood, you don't have oxygen, so cells die. So now when you think metabolic acidosis, think hyperkalemia. So hyperkalemia, muscle twitching, vasodilatation, so that's going to cause low blood pressure, nausea and vomiting, diarrhea, changes in level of consciousness, headaches. The brain doesn't like that vasodilatation, decreased blood pressure. Now there's that Kussmaul respiration. Now that's the compensation we're going to see. So that's that. Okay, this is the little boy breathing. You can watch his, you're going to hear the person talking, but watch his breathing. It's deep.
Basically, this, when we went to bed last night, his sugar was what? 99. Yeah, and then when he woke up this morning, he had a little trouble waking him up, and he was breathing like this, right? When was he diagnosed with diabetes?
So see how fast this
so
little boy.
he's,
I mean,
he's fine now.
he's probably in a coma.
Okay. And
Because that's when your blood sugar goes up like that, you go into a coma and you get this Kussmaul respirations. So that is, you're going to learn about diabetic ketoacidosis when you're a senior. But that's some heavy stuff. But you'll learn more about that later. But that's the Kussmaul respiration. It's deep and fast. He's just compensating. He's getting rid of what? CO2, carbon dioxide, which is an acid. All right. So now we're going to go into metabolic alkalosis. So the pH is up and the bicarb is up because bicarb is a base, right? So alkalosis. So see, you got table 818. So they can lose an acid or gain a base. So how can patients lose an acid? Yeah, don't we have hydrochloric acid in our stomach? So if someone vomits or they have NG tube, nasal gastrotube suctioning, like we're actually sucking out the stomach contents. Mild diarrhea, just mild diarrhea. But a lot of it is that vomiting, a lot of vomiting. So think of a GI bug can cause them to be in metabolic alkalosis. So let's look at metabolic alkalosis. So steroid use, steroids cause the potassium to go down. Remember? Al's K is low, alkalosis, low potassium. NG tube suctioning, vomiting, thiazide diuretic use. So this is IV infusions that have like albumin and lipids and carbs in them, citrated blood. Now remember, the citrates in blood will cause the what to go down? Citrates, calcium. So low potassium, low calcium, and low magnesium have a lot to do with alkalosis. And overdose on our barbiturates for bicarbonates for CPR. In CPR, we might give somebody bicarb. So they can have, just think low calcium, low mag, and low potassium when you think metabolic alkalosis. So if you can memorize your electrolytes, you can memorize your signs and symptoms. So the tetany, the convulsions, cardiac dysrhythmias, weakness, muscle cramping, hyperactive reflexes. So it's going to go along with your electrolytes. So there you go, metabolic alkalosis, the nausea, the vomiting, the diarrhea. So dizziness, irritability, anxiety, seizures, muscle cramps, tingling of the fingers and toes because of that low calcium. Remember the circummoral numbness around the lips. Confusion, dysrhythmias because of low K. Compensatory hypoventilation. Ooh, that's scary because of the low breathing. Causes too much antacid, so that's taking in too many bicarb. And then the NG tube suctioning, prolonged vomiting, and hypercortisolism. All right, any questions so far? metabolic. Now respiratory, we've got the pH is down, but the CO2 is up. Because remember, a respiratory acidosis, we slide down the pH, but CO2 isn't as acid, right? So if it goes up greater than 45, we've got respiratory acidosis. It all has to do with respirations. Respiratory acidosis and alkalosis has to do with respiratory lung stuff. So they've got decreased respiratory drive, they have lung disease, chest wall injuries, or paralyzed respiratory muscles, like someone who broke their neck and they're a tetraplegic, which is paralyzed from the neck down. So they're gaining an acid. So how can a patient gain CO2? They're not breathing it out. Can narcotic overdose cause respiratory acidosis? Because it's narcotics, opiates like fentanyl and morphine and Percocet slow down the respirations. That's why you can buy this nose spray called Narcan at the pharmacist. So if your loved one isn't breathing and they're on pain meds, you can squirt that in their nose and rescue them. Okay? We have a lot of people who are addicted to opiates. So, respiratory acidosis. So we've got oversedation, like from medications. So breathing too slow, hyporespirations. Brainstem trauma. So if our brain isn't our medulla oblongata and our pons aren't telling us to breathe, right? Immobility, because you're not taking deep breaths, and respiratory muscle paralysis from like spinal cord injury. Now, some people have respiratory acidosis, but they're breathing really fast, but there's something blocking the CO2 from getting out, like infections from pneumonia. The infection, the mucus and the purulent substances are not letting the CO2 out. So they breathe fast to try to compensate. And then pulmonary edema just means fluid in the lungs. And emphysema and bronchitis are lung diseases where the patient retains their carbon dioxide. They can't expel it out. But they might breathe fast trying to expel it out, but they can't. So we've got hypo, respirations and hyper. It's called tachypnea and bradypnea, which are the breathing, fast or slow. So respiratory acidosis, so of course hypoventilation, hypoxia, shallow respirations, low blood pressure with vasodilatation, dyspnea, headache, hyperkalemia, remember acidosis, hyperkalemia, dysrhythmias, drowsiness, dizziness, disorientation, muscle weakness, hyperflexia, and then those are all the causes we just mentioned. Atelectasis is collapsed alveoli. All right. So respiratory alkalosis. Respiratory alkalosis. So we've got low pH, and we've got, I'm sorry, the pH is high. pH is high, but the CO2 is what? Yes, CO2 is low because the patient's breathing it all out. So what do you think could cause respiratory, the biggest cause of respiratory alkalosis is
Hyperventilation.
a panic attack, an anxiety attack. So a panic attack, and so what we tell our patients to breathe, we'll have them breathe a paper bag. Because if they breathe out in the paper bag and then breathe in the paper bag, what are they rebreathing? Their CO2. We're giving them their CO2 back to them. Also, some lung diseases, if they do breathe fast, ventilator settings, we put them on the ventilator and we have a tube in their mouth that goes to their lungs, and the machine is breathing for them. It might be breathing too fast. It might be set too high. And then if us people who live on sea level, like Georgia's not, unless you go to like the mountains, and we go to like Colorado, we're going to be breathing faster because we don't have enough red blood cells and the oxygen's lower at higher elevations. So we're going to breathe faster. So a friend of mine went to a nursing conference up in Colorado, and she had a headache and dizziness the whole time because she was in respiratory alkalosis. So it's that deep, rapid breathing, respiratory, breathing. So the respiratory is all about breathing. So here's your respiratory alkalosis. So seizures, rapid breathing, hyperventilation, tachycardia, low or normal blood pressure, hypokalemia, remember Al's K is low, numbness and tingling around extremities, and that has a lot to do with just your carbon dioxide so low, it causes the numbness and tingling. If anybody's had a panic attack, you might have felt your fingers go numb. So Lethargy, confusion, lightheadedness, nausea and vomiting, and a lot of it is fear, anxiety, something called a pulmonary embolus. And we talked about the mechanical ventilation is the settings are too high. So, that is it, we did it. So, any questions? Whew, it's a lot.